Okay. Good afternoon. We'll start. I'd like to welcome everybody to this pep talk this afternoon. Please mute yourself, but always show your video picture. Sign in your name, your Facebook account, or email address in the chat box. Please include the names of companions attending with you in the Zoom. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures at the start and end of the pep talk. As a reminder, please take the online Learning Cum Evaluation Test exercise for mastery of learning and get a perfect score to get a certificate like the one shown below. I have placed the link in the chat box already. Another reminder, getting 50 OLETE certificates will entitle one mentee to a free voucher for ROJoson telemedical consultation as shown below. Another request is that please place your feedback in the chat box during the open forum. So let's now have a group picture taking before we start the pep talk proper in 2 minutes. Show your beautiful faces. Okay, one, 2, 3. I have a patient empowerment program which I'd like to empower the lay people or patients to take control in the management of their health. I started the pep talk on May 15, 2021. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. And from October 23, 2021 onwards, I've been tackling health disorder and health issue courses. This may take 3 years or longer, depending on the enthusiasm of our participants. My pep talk today is entitled Goiter Awareness. This is part of my contribution to the Philippine DOH's Goiter Awareness Week, which is being celebrated on the 4th week of January. The empowerment objective is for the lay people to have a basic understanding of thyroid goiter in their health management. I purposely used the word thyroid in the title and goiter in the title just for you to easily remember. When you talk about goiter, it involves the thyroid gland. The contents of this pep talk will be the following: what is a goiter, different types, causes, how to recognize goiter and its different types, what paraclinical diagnostic tests are usually done, and what are the usual treatment, and then what are the post-treatment management for goiter. Let's start with the first topic, which is what is a goiter? Loosely speaking, goiter refers to something wrong with the thyroid gland. So when you talk about goiter, you refer it to the thyroid gland. So the thyroid gland is a butterfly-shaped organ located at the base and central part of the neck. Sa gitna, sa gitna at sa harap. And goiter is simply defined as any disorder in the thyroid gland. I won't go to the history of the term anymore, but at the moment, this is the commonly perceived definition of goiter. Any disorder, any diseases, any medical conditions involving the thyroid gland. So the thyroid gland is a vital organ. When you say vital, it's one that is needed by the body to survive. Kung wala yan, mamamatay ho tayong lahat. Okay? So that regulates the metabolism, growth, and development of the human body. Okay? Kaya kung wala tayong goiter, magiging hypothyroid tayo, manghihina tayo, at hindi tayo lalaki, hindi tayo will not have a normal growth. The thyroid gland releases and controls the thyroid hormones that control the metabolism. So dito sa thyroid gland, may lumalabas na hormones called the thyroid hormones. Okay. And when I talk about metabolism, so basically the function of the thyroid hormones is to control the metabolism. And when we talk about metabolism, it's a process where the food taken into the body is transformed into energy. Yeah, pag walang thyroid gland, manghihina ho tayo. No? This energy is used throughout the entire body to keep many of our body systems working correctly. So just remember this definition. Okay. Goiter is defined as any disorder in the thyroid gland. As I said, I won't go into the history of the word thyroid kasi magulo. No? But at the moment, ito na lang tandaan ho natin. No? So what are the different types of goiter? It can be classified into several categories. One, by clinical presentation, whether it's diffuse or nodular, whether it's euthyroidism, hyperthyroidism, or hypo, okay, depending on the functions, on the secretions of the thyroid hormones. And then the other category will be based on the diseases, whether malignant or non-malignant, hyperthyroid or hypothyroidism. And then, okay, the other way is to categorize them by specific diseases, usually done by physicians. Okay. The clinical classification of goiter, when you say clinical, yung mga presentation sa outwardly, kapag nagpe-present sa inyo, in yourself, or when you present your body to the physicians, no? Okay, yan ang nakikita, no? So when you say clinical, it's usually signs and symptoms. So the clinical classifications of goiter that will contribute to the different types will be one, diffuse toxic goiter, meaning there's a diffuse enlargement of the thyroid gland like this one. Okay, kung ang size is just smaller than this one shown in the thyroid gland, then this will be the diffuse. Okay. O kaya kung itong normal, ganun ang laki. Okay. So almost all the lobes are enlarged. Diffuse non-toxic, ito toxic means you have hyperthyroidism. Non-toxic means you don't have hyperthyroidism, but you have normal thyroid hormones or euthyroidism ang tawag doon. U is normal, and then hypo kung kulang. No? Okay. So non-toxic can either mean euthyroidism or hypo. Nodular means may bukol-bukol. Okay. May signs of toxicity with hyperthyroidism. That's another category of the type of goiter based on clinical presentation. The nodular non-toxic goiter, okay, with nodules but without hyperthyroidism, may be euthyroidism or hypothyroidism. So in summary, just four of them: diffuse toxic goiter, diffuse non-toxic, nodular toxic, nodular non-toxic goiter. So these are the four main types as they present to us clinically based on symptoms and signs. Ito yung definition ng diffuse enlargement. No? So first thing that a physician does, or kayo rin, if you're empowered now, you try to palpate your thyroid gland. If it's palpable, normal size usually not palpable. So kakapain lang yung leeg ninyo, then you swallow. If you don't feel your thyroid gland, it's normal in size. Now, if it's diffusely enlarged, meaning there are two lobes in the thyroid gland, the two major lobes, the right and the left lobe. Kung medyo malaking dalawa, almost symmetrically enlarged, you call that diffuse. Diffuse, or you can call it generalized enlargement. But the term that we usually use, diffuse, no? Okay. To contrast it with nodule. So ito, kung ito yung normal size ng thyroid gland, tapos malaki siya, kabilaan, then you call that diffuse. Basta walang bukol. Ha? The moment may bukol siya, we call it nodular already. Ito yung nodule. Yan. It's either, kanina yung diffuse, almost, the two lobes are almost symmetrically enlarged. Pero kung one lobe is just, itong one lobe is 2 times, 3 times, 4 times bigger than the other side, we call that nodular already. Kahit na wala kayong nakakapangbukol, kasi kadalasan may bukol yan sa loob, hindi lang nakakapa. No? That will contribute to the increase in this size. 2 times, 3 times, 4 times bigger than the other side. Or, evidently, kung may bukol kayo nakakapa, no, then you call that nodular. Parang ito, nodule on one side, on the left lobe, and then ito, multiple, marami. Pwede mangyari doon. Okay? So we try to differentiate between diffuse and nodular because it will help us in the diagnosis. So ito, just to summarize, diffuse, almost the 2 lobes are symmetrically enlarged, and then sa nodular, either one lobe markedly enlarged and the other one, and then there are nodules. Okay? So when you have diffuse enlargement, now we talk of either hyperthyroidism, hypothyroidism, or euthyroidism. So it's based on the function. Okay. Now, when you talk about nodule formation, we now talk about whether it's malignant or non-malignant, kung cancer o hindi. Pag may bukol, we start thinking, cancer ba ito o hindi? Pero kung diffuse walang bukol, we start thinking on the function of the thyroid gland in terms of hormonal secretions. Kung sobra kaya marami ang sinisecrete, we call that hyper. Kung kulang, hypo. Okay? Kung normal naman, ang amount, euthyroidism ang tawag doon. So, the common diseases that I usually diagnose in clinical practice in the Philippines will be the following: hyperthyroidism, Graves' disease, this is special type, yung may lumuluwa yung mata, okay? Okay. And then hyperthyroidism, non-specified, unspecified means hindi lumuluwa ang mata, it's not part of the Graves' disease. So this is the Graves' disease is a special type of hyperthyroidism. Hypothyroidism, kulang ang amount of secretions of the thyroid hormones. And then acute thyroiditis means may inflammation or even infection of the thyroid gland. Then chronic thyroiditis is another condition, mayroong inflammation na matagalan dun sa thyroid gland, usually caused by autoimmune diseases. So 1, 2, 3, 4, 5 na, okay, diseases that we usually see in practice. Then the rest will be yung mga cancer of the thyroid gland, okay, papillary, follicular, anaplastic, medullary. These are the 4 common types that we see in the Philippines. Okay. For the non-malignant nodules, may mga bukol, as I said, kung may bukol, we determine whether it is cancer or not. Kanina, we talk about, I presented yung 4 common thyroid cancer. This time, I'm going to present to you the non-cancer nodules. So examples will be colloid cyst, may fluid ito. Okay, and then colloid adenomatous nodule, may combination of fluid and solid element, fleshy. Multiple colloid adenomatous goiter, this is one that has multiple nodules, 2 or 3 or 4 on one side or even on the 2 sides of the thyroid gland. And then I just put an asterisk here. This one belongs to this family. Ito isang spectrum of diseases ito. It usually starts with the diffuse, no? Diffuse colloid adenomatous goiter, enlarged lang siya, pero may problema siya. And then eventually it will magkakaroon ng nodule formation starting with 1, pwedeng colloid cyst, pwedeng colloid adenomatous goiter. Eventually, as time goes on, pwedeng multiple na, mas marami na. No? So it will be called multiple colloid adenomatous goiter. Now, what are the causes? Genetic predisposition, which we don't have any control there at the moment, okay? Environmental influence, like lack of iodine intake, but it's not very common nowadays, no? Excessive exposure to radiation to the neck, which can cause cancer, and then of course, stress. A note here will be that a lot of goiters have no definite known cause, except for the one that we talk about, iodine intake. Pag may lack of iodine intake, we can identify the cause, and then that will be the, we can say that that's the cause of the goiter if the patient is goiter, but the others, usually, we don't know the exact cause. More specific causes for the specific diseases of the thyroid will be iodine deficiency goiter, meaning there's a lack of iodine intake. Then colloid adenomatous goiter, this is due to physiologic and degenerative condition. You can say part of growing up, part of aging, okay, which is very common among women, okay. Cancer, this is due to genetic mutation with genetic predisposition, and radiation exposure is another common cause, okay? Excessive radiation exposure. Chronic thyroiditis usually due to autoimmune disease. Acute thyroiditis infection, hyperthyroidism usually due to an immune disease, and then hypothyroidism due to iodine deficiency, and or sometimes it's physiologic, meaning it's what do you call that? It normally not due to iodine deficiency, but somehow nagkakaroon siya ng hypothyroidism due to the usual causes. Okay. So, except for iodine deficiency goiter, which is due to the lack of iodine, which can be prevented, for the other diseases, one cannot really predict when one is going to have a thyroid disease. And two, the causes are realistically speaking, it's difficult to identify and to control. So, except for the iodine deficiency, mas madali. Healthy lifestyle with adequate iodine intake is the best bet against thyroid diseases. Ngayon, walang problema. We have a lot of salts which are iodized salt already, no? And then we eat a lot of seafoods, no? Okay. However, there is a percentage that one cannot prevent this thyroid disease from occurring even with a healthy lifestyle. We have to remember that. No? Probably 80%, 90% we can control, but there's a 10 to 20% that we cannot really control even if we practice healthy lifestyle. Kasi one of the causes, one of the factors is a genetic predisposition for genetic diseases. Okay. How to recognize goiter and its different types? So when you have a lump on the front, base, and central part of the neck, which moves up and down, kasi itong thyroid nito nakadikit doon sa trachea, the so-called trachea, yung windpipe. Pag nagsuswallow tayo, umaakyat baba yung trachea. Kaya yung thyroid sumasama. Okay? So knowing that the thyroid gland is inherently or intimately attached to the trachea, if there is something here that moves up and down, most likely it's the thyroid. No? So a lump on the side of the neck, dito sa side, it could be part of the related to associated with a thyroid disorder. You really have to check the thyroid and the neck. Kasi ito yung side of the neck, usually lymph nodes yan. Kung lymph nodes, usually we think of possible cancer if there is a nodule, if there is a buccal on the thyroid gland. Palpitation, yung mga quick, rapid heart rate, this could be a sign of hyperthyroidism. Hyper, kasi increased metabolism sa hyper. Sudden weight loss, ganun din. Okay, hyperthyroidism could be a sign. Sudden weight loss could be a sign of hyperthyroidism. Persistent fatigue, palaging pagod na pagod, usually a sign of hypothyroidism. Kulang naman, kulang sa thyroid. Ito, hypermetabolism, hyperfunctioning, kaya palpitation, sudden weight loss. Okay. So these three represent yung mga symptoms and signs of disorder in the thyroid function in terms of the thyroid hormone secretions. Ito naman, usually in terms of whether cancer or not, yung mga lump, yung mga bukol. So when you have persistent fatigue, it's a cue or alert sign for hypothyroidism. Okay, so kung palagi kayong pagod at without any known cause, no, hindi naman kayo palaging mabigat ang trabaho, okay, then you start thinking of possible hypothyroidism. Palpitation, sudden weight loss, these are cues for hyperthyroidism, hypermetabolic syndrome. Okay. And then lump, okay, whether on the front, on the neck, or on the side of the neck, then these are cues for tumors that could be either benign or malignant. So for the malignant one, you need more cues to determine whether it's benign or malignant. Okay. What are the paraclinical diagnostic tests that are usually done for goiter? So basically, these are the thyroid function tests, FT3, FT4, TSH, which determines the level of thyroid hormones in your body, in your blood. Okay. And then imaging procedures like ultrasound, thyroid scan, CT scan, MRI, PET scan. So these are examples. Okay. The most commonly done is still the ultrasound. And the needle aspiration of the nodule. Usually kung may nodule, itong ginagawa, no? Needle aspiration with or without biopsy. Kung fluid ang nakuha, you don't need biopsy anymore. Kaya may minus dito, negative. No? If it's solid, you really need to have it examined under the microscope. That's why you have the last biopsy. Okay. So thyroid function test, imaging, usually ultrasound. These are not commonly done, okay, by at least by me, but a lot of doctors are still doing this. So usually we don't do CT scan, MRI, PET scan because thyroid ultrasound will be good enough. Okay. Needle aspiration usually for mga bukol-bukol. So the thyroid function test will be used to check the level of thyroid hormones in the blood. So it will come out with the results that will tell you whether you have euthyroid normal, hyperthyroid, sobrang dami ang hormones mo, hypothyroid kulang. So the indications for this test, kung kailan gagawin. So when one is not sure whether the patient is hyperthyroid or hypothyroid, kung sure ka euthyroid, no? At sure ka naman, hindi na kailangan yung test na yon, normal naman, you don't have to do it, no? Okay? Pero kung nagsususpetsa ka possible hyperthyroid, kung minsan hindi clear-cut na hyperthyroid or hindi clear-cut na hypothyroid, then you go for this test. And then, once you have this test, you can also do another test to serve as a baseline. Muna, yung first one will be the baseline, and then after that, you can repeat the test when you want to monitor because yung treatment na ginagamit, no? Okay, let's say umiinom ka ng gamot for either hyper or hypo. Okay, after the first test na diagnose na, and after 1 month, you can repeat the test now to check whether tama na yung gamot na pinibigay sa iyo, yung gamot na iniinom mo, kung kasya na, no? So that's what is meant by monitoring subsequent medical treatment. The interpretation of these thyroid hormones, okay, or the thyroid function test will be if normal ang T4, TSH mo, T4 or T3, usually pwede ng isa no? But kung may normal FT4, FT3, and normal TSH, we call that euthyroidism, normal. Okay. If elevated, kung mataas yung FT4 mo, because this represents the thyroid hormones, okay, then we call the condition to be we label the condition to be hyperthyroidism, especially when the TSH is below normal. Baliktad ito, ito elevated, ito baliktad, bababa ito. Okay, this is how you interpret it. Now, if it's the thyroid hormones is below normal, meaning hypo kagad, and then the TSH is elevated, you label this as hypothyroidism. You suspect hypothyroidism. For the imaging procedures, so these are indicated when needed to evaluate the structure. When you say structure, kanina yung thyroid function test for the functions. Ito yung structure, yung korte ng thyroid gland, and then kung may bukol, gano'n, structure yon. Okay? So you want to evaluate the structure and at times the functions. Okay? Dito kasi may thyroid scan and also PET scan. The thyroid scan is used to determine the functions of the gland, whether ito, kung may uptake, maitim yan, may uptake, ito, walang uptake, cold ito, no? Okay, so yun ang functions, no? Okay, so there are several options. We just choose the most cost-effective one. Usually, as I said, ultrasound is the one being done most frequently. Ultrasound, this is an example of how you use the ultrasound, okay? And then thyroid scan, okay. So pag cold nodule, walang uptake, so puti ang lalabas. So this is walang uptake. But ito, hot nodule, so this could be a sign of hyperthyroidism. So yung tinatawag na nodular toxic goiter, no? May uptake siya. Needle biopsy, when needed to determine whether a bukol is solid or cystic, that's one information that you can get. So if cystic, makukuha ka ng fluid. You can see here, may fluid siya. No? Okay. So pag nawala yung fluid totally, it's therapeutic. Ibig sabihin, nagamot na, lumiit na. No? Okay. And then if it's solid nodule, you have to get a sample for biopsy. Papa-examine mo under the microscope. No? Okay. Check ko lang kung if I can play this. I'll check. Okay. So this is how a needle aspiration is being done. Nakaupo ka lang. Okay. Ako naman dito rin nakaupo, no? Ganun lang. Isang tusok lang, usually. And then aspirate. Nakikita niyo yung fluid may lumalabas. So this is a colloid cyst. This is benign. Okay. So what are the usual treatment for the different types of goiter? So options are watchful waiting, meaning observe lang, monitor lang, walang gamot, walang operasyon. No? The other option will be the medications, which could be for hyperthyroid or hypothyroid or for suppression, makontrol lang yung bukol. Operations is another option. Radioactive iodine is another option. And then third option is chemotherapy. So this is usually done for cancer, but usually if one has to resort to chemotherapy, it's usually in the far advanced stage. So for the non-cancer goiters, meaning hyper or hypo, okay, these are example of the non-cancer goiters, and it has the functional disorders, whether hyper or hypo. So, and the, okay, the other type of non-cancer goiters will be those with non-functional disorders, which are benign conditions. These are the so-called colloid adenomatous goiter. Okay, so the goals for treatment for these non-cancer goiters, whether it's functional or non-functional, you can have curative versus control. Okay, okay. When you say curative, it will go away. It will not come back. Control, it can come back, but at least it can come back in the future. But at the moment, you try to decrease the size to resolve it now. Okay. Then we have to remember that some don't recur after treatment, but there's always a possibility that some can recur. So only time will tell. So even for benign one, for non-cancer goiters, no guarantee for cure. Then you may need a lifetime medication, maintenance medication. Okay. Just like when you're taking antihypertensive drugs for your hypertension maintenance. You know. Now, specifically for hypothyroidism, yung kulang, no, medical therapy. We don't allow yourself to be operated on because this will just aggravate the hypothyroidism. Kasi with operations, you have to remove more or even part of the thyroid gland, which will decrease further the amount of thyroid tissues that will secrete thyroid hormones. Kaya makukulang, lalo na kung tinanggal lahat, di lalong hypothyroid ka kasi wala na yung thyroid gland to secrete the thyroid hormones. So for the treatment of hypothyroidism, kasi kulang, so you have to replace, dagdag. So you usually give thyroid hormones, usually levothyroxine. Kung permanent yung hypothyroidism mo, usually lifetime ang gamutan, forever. Now for hyper naman, yung sobra, now 3 options, okay? Depending sa size of the nodule or yung size of the goiter, okay? So you can try with medical therapy, with anti-thyroid drugs for those with smaller goiter. And then kung malaki na kahit na makontrol mo yung thyroid hormones niya, pero halatang halata, pangit tingnan, malaki yung bukol sa leeg, then we can do operations. Okay. The other option is radioactive iodine therapy. So we give this radioactive substance to burn the thyroid gland para konti lang yung matitirang thyroid gland that will secrete the right amount of thyroid hormones. Dito sa operative treatment, binabawasan yung kinakat, tinitrim yung thyroid gland para mas konti na lang yung thyroid gland that will be enough to secrete the right amount of thyroid hormones. Again, as I said, for huge size goiter, yung malaking-malaki, halatang-halata na the treatment of choice usually operation na. Okay. Now, for the colloid adenomatous goiter, these are the benign conditions, but these are not hyper or hypothyroid. As I said, there are 4 categories, starting with diffuse. Then, as time goes on, it will become a colloid cyst. Sometimes it can go into a solitary, isa lang muna, and then eventually multiple, marami. So the options here will be, kasi benign naman ito, hindi naman cancer, you can monitor without medicine, kung maliit lang, at usually hindi ka naman nababothered, or you can use medicine, levothyroxine, to control or to decrease the size. Then if it's big, yung goiter mo, it's big, then operation is needed. Here, as I said, as mentioned here, operation is recommended for huge size goiter. For small to moderate ones, no operation is needed. Just monitor without meds or with meds. You can try out, I call it trial of medical therapy. Kadalasan lumiliit, pero up to a certain extent, kung di siya lumiliit, you just take a maintenance medicine para hindi lang siya lumaki. Okay. So for treatment for either those with functional disorders, and with functional disorders, usually after all this either medicine or operation, you need surveillance, meaning you have to monitor, okay, because it might recur, and the monitoring usually lifetime. For the treatment of thyroid cancer, these are the 4 types of cancers. The most common still papillary, then follicular. Okay, this medullary is very rare. Anaplastic is a little common, but not very common, especially in mga may edad, matatanda. The usual goals of thyroid cancer treatment, talking about thyroid cancer, will be either curative or palliative. Curative means the aim is to cure para hindi lang siya bumalik, no? Okay. Palliative means hindi mo na matatanggal lahat, no? Iko-control na lang. Okay. So when you say curative goal, it's eradicating all known or all observed tumors entirely. Lahat tatanggalin mo. So you try to prevent the recurrence or spread of the primary cancer. And then palliation means you relieve the symptoms if you cannot remove all the tumors. So if all reasonable curative approaches has been exhausted. No. For the curative goal sa thyroid cancer, if it's operable, then operation is the best treatment. This can be followed by radioactive iodine therapy, susunugin yung naiiwan na thyroid tissues, and then this can be followed by a medical suppressive therapy. Yung medicine sometimes can help control the recurrence. So palliative goal, you can give chemotherapy and radiation. So once we have a patients who have been recommended for chemotherapy and radiation therapy, it just implies that the treatment goal will just be palliation, hindi na curative. And operations being done for thyroid cancers will be the following, usually total, subtotal. Subtotal means hindi lahat tatanggalin, total lahat tatanggalin. And then neck dissection, kung may kulani dyan sa side of the neck, kung may nag-spread na dyan, then a neck dissection can be done. There are different kinds, which I will not explain it here anymore. What are the post-treatment management? So after treatment for any type of goiter, whether non-cancer or cancer goiters, there must be surveillance or check-up, follow-up, usually lifetime or recurrence, baka umulit. No? Early detection of recurrence, no? When the check-up, we try to detect early detection, and then with early detection, mas maganda early treatment. With early treatment, you're assured of a better outcome. Patients may be taking maintenance medicine for control of disease, maybe lifetime. Some of you probably are taking medicines up to now for so many years now. So yan ang maintenance. The patients are advised to have a healthy lifestyle to promote health restoration and maintenance. Now, except for anaplastic thyroid carcinoma, this is the worst cancer. Okay. And fortunately, it's not very common, it's rare. Okay. And advanced cancer, the rest are still have a long life after treatment. Yung papillary, follicular, medullary, they still have a good chance to stay alive for a long time. So summary and takeaway for this talk will be the following. What is goiter, different types, causes, how to recognize, clinical diagnostic procedure, usual treatment, and post-treatment management of goiter. Takeaway in relation to patient empowerment, be always in touch with reliable medical information on thyroid goiter. Knowledge is power, it gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of thyroid goiter. So with this, I end my pep talk. I hope I have empowered you to have a better and basic understanding of the thyroid goiter in your health management. So before we go to the QA, again, reminder, the OLETE and also the 50 OLETE certificates will entitle you to 1 voucher for ROJoson medical consultations. And then feedback, please type in your feedback at the chat box. Okay, so let's now have a group picture taking before we start the QA. Okay. Are you all ready? Lordy, you show your face. Very good. 1, 2, 3. Okay. The floor, we have still 20 minutes. Okay. The floor is now open for open forum. Questions, sharing of experience, comments. Who has experience with thyroid goiter already? Okay, Perla. Sino pa? Siya lang, si Perla? Okay. So you like to share your experience, Perla?
Last 1999, doctor, I was operated with multiple colloid adenomatous goiter.
Okay.
Luckily, fortunately, it was benign. I was operated at the Manila Doctors Hospital by Dr. Arturo de la Peña.
Okay.
Doctor, okay naman, pero ngayon, nagte-take ako ng L-Truxin. Kasi yung aking TSH is nagpla-fluctuate daw. Minsan mababa, minsan mataas, minsan normal.
Okay.
Oh.
Okay. Okay. So I'm glad you mentioned the word multiple colloid adenomatous goiter. Saan mo nakuha yung pangalan niyan?
Doon po, doktor, sa
Istapat.
operation, yung di ba mayroon siyang binibigay sa record na yung record of operation ba yon? Yung mga
Yeah, operative record.
Yeah, operative records, doctor.
Yan ang
Kasi hanggang ngayon may nakatago pa po ako, doktor eh.
Okay. So, pero yung sa histopath, anong nakalagay?
Para yun nga, multiple colloid na may mga na-drawing, na may mga nodules, ganun. Pero, benign po yun.
When I say histopath, yung pathologist report yon. Walang drawing yon.
Wala.
So, yung sinasabi mo, operative records.
Opo.
Yung may drawing.
Meron pa ako yung drawing.
Sino nag-draw noon? Si Dr. De La Peña?
Dr. De La Peña.
Okay. Kailan ka na-operan?
June 1999, doctor.
Okay. So may drawing siya. And then,
Opo, may drawing siya.
so we're talking about the operative record. We're not talking about the histopath.
Oho.
Okay.
May drawing siya kung ano
Okay,
yung goiter, para may ganun siya.
Okay yun. No? Kasi what I
Oo.
want to bring out is yung mga terminologies. No? Okay. So, a lot of doctors do not use the word MCAG. Yan ang multiple colloid adenomatous goiter. No? Okay. So, I'm glad that you mentioned it. No? Yan ang ginagamit ko. No? But a lot of yan din ginagamit ng mga pathologists. But yung mga ibang doktor, they don't use it. No? They use it nodular NTG, sabihin, nodular non-toxic goiter, gano'n. Iba-iba, no? Okay. Yep. I'm just happy that you were able to use the term that I usually use. Tama yon. And it so happened, most likely, I was able to influence. Dr. Del Peña was once my student. May influence ako sa kanya. So, she used the word, the phrase, multiple colloid adenomatous goiter. Okay, yan ang very descriptive of the what you have, yung condition mo sa thyroid, no? Okay. Very good, no? Okay.
Ang ano ko lang, doktor, kasi once na nagpa-check up ako kay Dr. De La Peña, hindi niya tinignan kung this is curable pa o ano, basta operan daw ako. O hindi ko pa naman po kayo kilala noon. Kasi
so, anong diagnosis pinigay sa iyo before the operation?
Parang hindi naman niya ako, tinignan lang niya ako. Sabi niya, operahan daw. Oo.
Okay, so hindi niya in-explain kung anong meron ka.
Hindi naman po, doktor.
Pero yung
sa
operative records, meron na multiple colloid adenomatous goiter.
Adenomatous goiter, opo.
Okay. Anyway, most likely, kasi yung goiter mo, malaki na ba? Malaki? Marami? Maraming bukol-bukol?
Parang meron nodules, tapos parang bang akyat baba. Pag nagsalita ako, parang sumasama, gumaganon siya.
Tama, di ba sabi ko, pag tumataas baba, thyroid yon. Yan ang clue.
Oo, tumataas baba. Parang Adam's apple ba ng lalaki na gumaganon.
Okay. So, to everybody remember that, yung mga bukol diyan sa gitna ng leeg, no? Basta baba, taas, thyroid yon, usually thyroid. 99% thyroid yon, no? Okay. So, yun sa iyo, maraming bukol, kaya inoperahan ka. Okay. So, kung curable, siyempre walang sasabi ng curable kasi mahirap i-explain eh. Kasi when you say curable, strictly speaking, it doesn't recur. Pero sabi ko sa iyo, pwede mag-recur kahit benign siya. No? Okay. More so if it's cancer, no? Pwede
that was 1999, di more than 20.
Okay, kaya most likely hindi na magre-recur yan. Most likely. Again, I cannot, nobody will play God, nobody will say 100% di magre-recur, no? Okay. Pero 99% of chances are hindi na siya magre-recur, no?
Sana nga,
okay. So tinanggal lahat, total thyroidectomy.
Total thyroidectomy.
So pag total, usually wala ka ng thyroid, kulang yung thyroid hormones mo. Tama?
Opo.
Okay, so yung T4 mo, after the operation, before the institution of medications, mababa ang T4 mo. Tama?
Siguro,
mababa?
doktor.
Nakalimutan mo na. Okay. Okay. And then yung TSH mo, okay, mataas naman. Okay?
Minsan pag mataas, kulang daw yung gamot. Pag mababa, sobra daw yung gamot. Kaya na-adjust ng doktor ko yung pag-inom ko ng gamot, doktor.
Ilang tabletas ang iniinom mo ngayon?
Ang ginawa ng doktor ko, doktor, is TTHS 50 micrograms, MWFS 100. Ganun ang nag-adjust siya, doktor eh. Hindi na 100 na everyday. Basta TTHS milligrams. MWFS. So far, nung nagpa-ano ako nung last na check-up ko, normal naman, doktor. Kaya ganun lulit ang schedule ko pag inom.
Okay. So, tinanong mo sa doktor mo kung bakit ganun ang scheduling?
Yung
Bakit
kwan,
hindi
doktor,
pare-pareho?
yung pag-inom ko.
Oo. Bakit TTSH?
Kasi nga daw, doktor, kasi sobra. Noong nagpa-TSH ako, mataas yata o mababa. Kulang daw. Pag mataas, kulang daw.
Okay. Na, ang tanong ko sa iyo, tanong mo sa doktor mo, bakit in certain days mababa, in certain days mataas ang dosage? 50, yung isa 100. Tanong mo lang, ha?
Opo.
Para may matuto tayo kung anong reason. Kasi
Okay,
iba
doktor,
naman,
babalik.
kailan balik mo?
Sa March, doktor.
Sige, tanong mo lang bakit ganon, ha? Para may matuto tayo at sabihin mo rin sa akin kung bakit. Okay. Okay. Kasi ang
Okay, doktor, okay.
yung practice ko, I give it tuloy-tuloy na lang, pare-pareho para hindi na malito, no? Okay.
Oo nga, hindi lang sinusulat ko nga sa kalendaryo. Pag inom ko, anong iinumin ko si kakalimutan ko.
Mahirap tandaan, di ba?
Ano iinumin ko? 50 o 100?
Mahirap tandaan. Saka
Oo
nagpa-fluctuate
nga,
na.
doktor eh.
Kahit na pare-parehong dosage mo, nagpa-fluctuate talaga yung values noon, no? Okay.
Opo.
Kasi pag nakuha mo na yung trend, you actually don't have to have your test anymore, no? Yung mga TSH, no?
Pa-TSH, babalik na naman ako, doktor. Pa-TSH na naman ako. Every 3
Usually,
months.
sa akin, pwede nang hindi na. Basta nakuha mo, basta at least 50 o 100, gano'n.
Ganun ba?
Nagpa-fluctuate talaga. Basta importante
Doktor,
may iniinom ka.
oo po, doktor. Pero, doktor, parang aywan ko kung related dito sa ating topic, no? Pwede ba sabihin ko?
Sige, go.
Last Saturday, kahapon lang, doktor, nasa Manila, doctors ako. Nagpa breast ultrasound, tapos dito sa whole abdomen, sa breast. Gusto ko nga ipabasa sa inyo, doktor. Pati sa aking mamo. Hindi ko alam kung kailan ako pupunta. Magpapa-sked po ba ako?
Hindi
Ganun.
na related sa topic.
Hindi na nga, doktor.
Next.
Kaya lang gusto kong
Next
ipabasa sa inyo.
Kala ko sa thyroid eh. Okay.
Hindi,
Sige,
doktor.
we'll discuss it some other time. Okay? Some other
Okay,
time.
doktor.
We'll give
Okay.
other a chance to talk, to share.
Okay, doktor. Kaya nga sinabi ko, hindi na related. Sorry, doktor.
Okay.
Okay po.
Okay. For the others, any questions? Any sharing?
Yeah, from Jocelyn P. A
Okay.
friend asks who are candidates for radioiodine therapy. Radioiodine therapy.
Who are candidates for radioactive iodine therapy? Two types of patients. Number one, you may hyperthyroidism. Radioactive iodine therapy is being used. And then the other will be those with thyroid cancer. No? Okay. So, yung RAI therapy is used to burn the thyroid tissue, okay, or to burn the thyroid cancer. No? So in patients with hyperthyroidism, no, di ba, yung kabilaan may glands yun, di ba? Okay. So, pwede magbigay ng RAI para sunugin siya para kumonti yung active na thyroid substance or thyroid gland. Okay? Kung konti na lang natitira, konting thyroid hormones na lang ipoproduce niya. No? Okay? That's the rationale about in using thyroid RAI in hyperthyroidism. Okay? Now, for those sa thyroid cancer naman, it can be used either after an operation, pag di tinanggal lahat ng surgeon yung thyroid gland, gagamitin ng endo, no? Susunugin niya yung remaining thyroid gland, no? Okay? Para walang matirang para hindi mag-recur, ganoon, no? Or kung meron ng kumalat for thyroid cancer, kung may kumalat na sa ibang lugar, then you can use the RAI to burn those which have been which have spread to other parts of the body. Okay? So candidates for radioactive iodine, number 1, pwedeng patients with RAI, with hyperthyroidism, and patients with thyroid cancer. Dalawa. Okay? But case to case, hindi lahat. Okay? I'm just talking about the 2 types of candidates kasi ang tanong mo, candidates, di ba? So, hindi man ibig sabihin all of them should receive the RAI. No? Okay? Did I answer your question, Jocelyn? Mute. Unmute. 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 Jocelyn, unmute.
Ay, sorry, Doc.
Okay.
This is not my case, so I'm not so knowledgeable yet. My friend is trying to enter our Zoom. I don't know kung successful na siya nakapasok. Hi, Jo. Wala pa yata. So,
Wala.
anyway, I recorded your answer, Doc. I'll just convey it to her.
Okay.
Thank you, Doc.
Okay. So, okay.
Kasi gusto na sana niyang magpa-RAI, pero the doctor said she is not a candidate. So, kaya nga meron siyang question na, ano ba yung candidate for RAI?
Is she a thyroid cancer patient or hyperthyroid?
Fluctuating or between hyper and hypo. Hindi siya definite kung ano eh. Pero hindi cancer patient.
Okay. So, hindi cancer patient. So, most likely hyperthyroidism ini-entertain ng doktor. Na?
Mm-hmm.
Okay. But make sure that kung talagang hyperthyroidism, kasi pag binigyan ng RAI, hindi naman siya hyperthyroid, no? Susunugin lang yung thyroid gland niya, magiging hypo naman siya, babaliktad. Babaliktad, no?
Sa case kasi niya, baliktad eh. Hindi stable na kung ano.
Yeah.
If not hyper, nagiging hypo. Ganun lang, pabalik-balik.
Kaya nga. So, okay. So, how can I help you? Ask her to see me na lang. Okay.
Okay. Anyway, I'm recording this conversation. Thank you, Doc.
I really have to analyze the case to be able to help you in details now. Okay.
Okay, thank you. She cannot enter our Zoom.
Okay.
Okay. Thank you. Our time is up na rin, Doc eh.
Sige. Ask her to join us in the Zoom as often as she can. Okay.
Okay, thank you.
Any more questions?
No more, Doc. Happy Chinese New Year.
Happy Chinese New Year. Okay. Okay. So any other questions from the others who have experience or ano? Wala na? Are you in a hurry to celebrate the Chinese New Year?
No. Mamayang gabi pa, Doc.
Okay. Wala na? Wala nang tanong?
Wala na.
Sharing of experience. So, levothyroxine. Wala na rin tanong sa, ano. We still have 5 minutes to go. No? If you want to ask questions. Yesterday, I had, Rochelle, are you going to ask questions? Yesterday, I had sige. Kasi nakita ko nagbe-blink yung ano mo Rochelle. Are you going to ask questions?
Sorry, Doc, if it's blinking. Not really a question, Doc, pero sharing na lang siguro.
Sige.
Kasi nung 2021, I had my blood test, yung TSH, FT4, and then FT3. Ang mataas po sa akin that time was TSH. Slightly elevated po siya. And then, nagkaroon na rin po kasi tayo ng topic sometime ng 2022 about goiter. So, I
Yeah.
also asked you this question.
Uh-uh.
Ang sabi mo sa akin at that time, your advice sa akin is just kung wala naman akong symptoms, mag-antay na lang, kumbaga, and observe. Parang gano'n. Or, for my peace of mind, you told me at that time, kung gusto ko, ipa-repeat ko. But I did not do the repeat test, Doc. So, wala naman kasi akong symptoms. And then, last December, I had the same test. Normal naman na po lahat. Yung normal FT4, TSH, and then FT3. So,
good.
Yun nga po, Doc.
Thank you for sharing. Yan ang palagi ko sinasabi sa lahat ng tao, sa lahat ng doktor, no? Yung hindi ko lang ma-document talaga in a formal paper. Ang napapansin ko, maraming inconsistency sa TSH, no? Maraming inconsistency. Ewan ko kung sa Pilipinas lang yan or even abroad, no? Okay. So sabi ko, even ako, nangyari na sa akin yon. You can call it I'm a victim, but because I'm a doctor, kaya hindi natuloy. So 4 years ago, when I had a thyroid function test because pinilit ako ng asawa ko kasi sabi niya palagi akong tulog ng tulog, no? So nagpakuha ko ng thyroid function test, T3, T4 normal, TSH mataas. Okay? So pag mataas, ibig sabihin hypo. Yan ang usual yung interpretation ng mga endocrinologists saka yung mga doctor, they just rely on the TSH, no? So pag mataas, ibig sabihin iinom ako ng gamot, no? Levothyroxine kasi hypothyroid ang diagnosis doon, no? So ang ginawa ko, I just repeated my test after less than 1 week para sabi ko habulin ko to recheck, no? So normal lahat, no? So that was 4 years ago. Up to now, I have not rechecked it. Wala man ako nararamdaman, no? So there were a lot of other patients whom I have counseled, no? A lot of other doctors just base their diagnosis on TSH, pero wala siyang nararamdaman, no? Kung minsan yung TSH masyadong mababa, at wala naman siyang nararamdaman na hyperthyroidism, walang fatigue, walang palpitations, no? Sabi ko sa kanila, sige, itigil mo yung gamot mo kasi binigyan na silang for hyperthyroidism. Then itinigil, then after 1 month, inulit yung test niya kasi uminom siya ng gamot, no? So I asked her to stop the medicine first. And then after that, repeat the test, normal, no? So from my observation, no? Baka ganun din Jocelyn, Jocelyn Tejas, sabi mo lang, yung mga test kasi nagpa-fluctuate, no? Perla, nagpa-fluctuate din yan, no? Kaya, lumisan, hindi mo malaman kung which one is correct now, no? Okay? So, day by day yan, nagpa-fluctuate kuminsan because of your mood, because of your system, or sometimes because of the machine, yung machine na ginagamit dun sa, yung mga reagents na ginagamit sa laboratory, no? Okay? So sa akin, what's more important is to rely on the clinical, no? Okay? Okay. So maraming Kaya just beware of that, beware of that what do you call that? That things that usually happen, nagpa-fluctuate na hindi mo malaman kung which one is the correct one, no? Ganon. Okay. So thank you for sharing, Rochelle. It just validate my observation, no?
Thank you din po, Doc.
Okay. Okay, kung wala na, any more? T3, T4, and then MRI. As I was saying kanina, I had a group of students yesterday, ganun din. So, tinuturuan ko na impression kagad na multiple colloid adenomatous, multinodular non-toxic goiter, then secondary diagnosis is CA. tinatanong ko, saan nyo nakuha yung terminology na yun? Kasi these students came from a different schools, UE, FEU, no? Sabi ko, yan ba'y tinuturo sa inyo? Okay lang kung ano, sabihin lang nyo sa akin kung yan ang tinuturo, no? Pero ay sabi ko, even WHO, no, ang terminology ginagamit niya, no, medyo I'm not sold to what WHO is teaching, no, yung they call it multinodular non-toxic goiter, no. It's a clinical classification. It's not really a diagnosis, no. Ang diagnosis is multiple colloid adenomatous goiter. Yan ang ano. Yan ang natuto ko sa aking yung mga teacher dati, which I believe because after the operation, binibigay ko sa kanila, then binabasa nila, di ba? So they call it multiple colloid adenomatous goiter, which I agree, no? Because it's very descriptive of the pathology, no? Okay. So a lot of times yung mga terminologies is a problem in the management of patients, no? Okay. So medyo magulo pa lang, no? Okay. So any other comments before we call it a day? Kung wala na, so we call it a day. Happy Chinese New Year to everybody.
See you.
Okay. So next week, anong topic next week? I might talk, hello? Somebody's raising his, okay. So next week, I'm not thought of a topic, but it might be on the rare disease muna, rare disease, no? Okay. Kasi I'm following the DOH calendar, no? Although February pa yon, no? I might insert it next week, no? Rare diseases in the Philippines, no? Okay. 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 If there are no more questions, let's call it a day.
Thank you, Doc.
You're welcome.
Bye-bye.
Bye-bye.
Thank you, Doc.
Bye-bye. Happy Chinese New Year to everybody.
Happy Chinese New Year, Doc.
Thank you.
Bye-bye.